Health Matters family. I hope you enjoyed the previous two sessions. As you know, we had Dr. James Bennett talk about prostate cancer. Dr. Bennett's credentials are just impeccable. So you really had access to a real thought leader when it comes to prostate cancer in African American men. And of course, we had Dr. Linda Bradley, who again is just another thought leader and completely committed to her community. I hope you guys get a chance to look at her bio and go to Cleveland Clinic and see the institution that she's built, which is called Celebrate Sisterhood. That will take place within the next couple of weeks. It's a virtual program, and Dr. Linda Bradley helped to create Celebrate Sisterhood. So now we're going to talk to you about breast cancer. As you know, this is Breast Cancer Month, and we really want to educate that it is not a death, it doesn't have to be a death sentence. If we catch it early, you can thrive. I've heard of Black women getting triple negative and surviving it. So we want to give you the knowledge that you need so that you can move forward, you can check your breasts, and then you can access the best possible care by interacting with doctors like we have today. I just want to give you a quick couple of facts on breast cancer. According to the Center for Disease Control and Prevention, Black women and white women get breast cancer at about the same rate, but Black women die from breast cancer at a higher rate than white women. So we've got to change that, and we can change that. Breast cancer is most often found in women, but men can get breast cancer too. About 1 in every 100 breast cancers diagnosed in the United States are found in men. We've got to keep our brothers aware that this could also happen. Now, another thought that is very important to consider is you may have breast cancer even if you don't find a lump or feel a lump in your breast. So let's just be hypervigilant all the time, and we'll manage our risk factors for success. I take pleasure in introducing you to Anita Johnson, who is Chief of Surgery and the National Director of Breast Oncology at Cancer Treatment Centers of America. She is board certified in general surgery and a fellow of the American College of Surgeons. Dr. Johnson received her medical doctorate at Morehouse School of Medicine and was the first woman to complete the general surgery residency program. So it was with great pleasure that I introduce you to Dr. Anita Johnson. Thank you.
Good morning. I'm going to go ahead and share my screen. And we'll get started with our talk. So we're just going to go over a couple of initiatives and just give you an update on breast cancer. And we've already gone over my background, so we'll just eliminate that. So our objectives include screening guidelines, high-risk genetic testing guidelines, imaging initiatives, surgical options, as well as triple negative breast cancer we will discuss, as well as some lifestyle modifications that you can use. So as she stated earlier, breast cancer is well known in the United States. We still continue to have the highest incidence in the world. And what we know now is that by 2030, it is projected in the world that there will be a 50% increase in the diagnosis of breast cancer. And women who are noted to be high risk can have up to an 80% chance of getting breast cancer in their lifetime. So some of the risk factors include obesity, particularly after menopause. Your risk does increase, as well as if you're diagnosed with breast cancer and you're obese, your prognosis is poor. Alcohol consumption has become a key factor as well. Consuming more than 2 beverages a week will increase your risk of breast cancer. And if you wait to have your first child by the age of 30, that can increase your risk as well. And we also know that family history is important. So let's talk about exercise. It is so key for our overall well-being. There was an important study done just a few years ago in which they looked at over 1,000 women, and those breast cancer survivors who actually exercise About 2.5 hours a week, moderate exercise, actually decreased the risk of recurrence and death. Now, if you did a more vigorous regimen, you also decrease your risk of recurrence and death. After being diagnosed, approximately 2 years, you had a drop in recurrence rates of 55%, and death rates were decreased by 68%. So when we're doing our breast exam, of course, we're always looking for a lump. We're looking to see if your nipple starts to pull in somewhat, if you have some dimpling of your skin, if you notice any skin changes or any nipple discharge. Nipple discharge that is of concern includes discharge that comes out freely without you pressing on your nipple. If it's clear, if it's red, that it is of concern. But milky or green or blue, that's fine. So the bottom line with African American women, and for all women, I strongly believe that mammograms should start at a minimum age of 40 years old and should be done every year, particularly for African American women because they're diagnosed at such a younger age. So a lot of women strongly feel that they have a dense breast tissue. And so this picture here shows if you have dense breast tissue noted on your mammogram. The far right mammogram shows dense breast tissue, and the far left is a fatty replaced breast. Calcifications are oftentimes seen on mammogram. 85% of the time, though, they are not cancer. And so here, though, they look very suspicious. But just note that if you get a call back on your mammogram, in majority of the cases, it is a benign finding. This is just a picture of a cyst. A lot of women have breast cysts. They have less than 1% chance of cancer. You usually don't need surgical intervention to remove these. And this is an ultrasound, just shows you the difference in how cancer looks on the ultrasound. So as you can see on the right side, cancer is more irregular shape. It looks kind of angry on the ultrasound. So what's key, and I'm really passionate about, is women knowing their family history. Because what we know as physicians is if you have a mother, sister, or daughter who's been diagnosed with breast cancer, that you have up to a 50% chance of getting breast cancer. Other cancers that are important include prostate, ovarian, as well as colon cancer. A strong family history may indicate that you need to have genetic testing done. So being high risk is knowing that you're high risk is very important. And so you need to see a high risk provider. Usually that's a breast surgeon, and they will do a risk assessment for you. And if that number comes back higher than 20%, then you are noted to be high risk. As well, you can note that you may have a genetic mutation that makes you high risk as well. Or you could have had a needle core biopsy in which pathology findings were consistent with atypical cells. So what's new when it comes to genetic testing is that what we know today is that most women who get breast cancer, they will not have a genetic mutation. But those few who do, it's less than 7% of all breast cancer cases. There are only 4 genes which will put that woman at risk of getting breast cancer in the opposite breast. And those genes include the BRCA mutation, the P10, the TP53, as well as the PALB2 mutation. So if you are noted to be high risk, we oftentimes put you on medication. There are certain drugs that your physician will recommend. We also recommend that you see a breast surgeon every 6 months. At one time, you'll get a mammogram, and the other 6 months, you will get a breast MRI. And in the most invasive procedure that could be done is a prophylactic mastectomy. At our facility, we actually, for women who have significant breast size, we offer them a breast reduction so that they can keep their nipple areola in place. So if you are diagnosed, what you should know is the type of breast cancer that you have, whether it's ductal, lobular, or ductal carcinoma in situ, and you need to know the hormone receptor status, the size, and if there's any lymph node involvement. So how big is a centimeter? So women will come in, they say, well, you know, my lump is about a pea size. That's actually 1 centimeter in size. Once you start getting a significant size, such as the size of a walnut, that is actually 4 centimeters in size. So what's important to know, as I stated earlier, is that the receptor status of your breast cancer. So you see on the right of this screen, this is a cancer cell in the pink. And so sometimes there are receptors that lie on those cells, which include estrogen, progesterone, as well as HER2/neu. Now, the pink figure on the far right, that's actually triple negative breast cancer, where that cancer cell does not exhibit any receptors at all. So triple negative breast cancer is often, discussed when we talk about breast cancer in African American women, but triple negative breast cancer is actually seen in all races. Here's a famous woman that has survived triple negative breast cancer. So triple negative breast cancer are cells that do not express estrogen, progesterone, or HER2/neu. It's more common in women who are African or Hispanic descent. The incidence is about 27% in that patient population. It may be associated with a BRCA mutation. It always requires chemotherapy, and the surgical options though remain the same. Women still have the option of keeping their breasts intact, but it does have a higher chance of recurrence in 1 to 3 years. So immunotherapy, a lot of women come in, they want to have immunotherapy. The only women who are candidates to have immunotherapy include women who are what we call HER2/neu positive. And so there's a drug regimen that is targeted towards that receptor. And what we now know today is that the outcomes for patients who are HER2/neu positive, who complete the standard of care regimen, actually have a really high outcome as far as the survival rates. Triple negative breast cancer and HER2/neu positive breast cancer today, oftentimes we treat before surgery in order so we can evaluate the tumor cells after systemic chemotherapy has been given. If there are very few cells noted at the time of surgery, then we know as physicians the risk of recurrence is much lower. So we're going to do a few quick cases. This is a 46-year-old African-American female. She felt a lump approximately a few months ago. It was about 3 centimeters in size. What's significant with her is that her sister was diagnosed at the age of 49. Her mom had colon cancer. And so we did a biopsy, came back with invasive ductal carcinoma. It was triple negative. So when we looked at her case scenario, because she was a young age, as well as had a family history, as well as being triple negative, we did genetic testing on her. She did not have a mutation, and this is very common. Most women with a family history of breast cancer do not have a genetic mutation. So we referred her to our medical oncologist because the mass was significant in size, as well as she had a triple negative type of breast cancer. We started chemotherapy up front. When she returned, we discussed the surgical options with her. She had great choices for surgery. We discussed with her that a lumpectomy plus radiation equals to having a mastectomy with immediate reconstruction. And we also did what's called a sentinel lymph node biopsy. So when we talk about surgical options, what women must know is that if you have breast cancer and it's only in one area of your breast, I always tell my women that that is the only part of your breast that's been affected. So what we know today, and we've known for over 25 years, is that in early stage breast cancer, a lumpectomy plus radiation therapy equals to having a mastectomy. Some women who choose to have a mastectomy have great choices as well. It depends on your body habitus. In some cases, we are able to save all of the skin and all of the nipple, and the majority of our patients are offered immediate reconstruction at that initial surgery. So what's new today, and it does depend on where you go, women who are candidates for breast conservation, we often offer them what's called oncoplastic approach. And sometimes we go at where your bra hits you at the bottom and take out the tumor. Sometimes we go through the areola and kind of tunnel up and remove the tumor so you don't have a visible scar. And sometimes we use a small incision under your arm to remove the tumor so you won't have such a visible scar. So what's clear, what should be clear to you is that the type of surgery that you choose does not eliminate the need for chemotherapy. There are patients that come in who have triple negative breast cancer, who need chemotherapy, and their thought is that if I have bilateral mastectomies, then I won't have to have chemotherapy, and that is just not the case. Breast conservation is an option, as well as mastectomy with immediate reconstruction. And what most women should know, if you need to have a mastectomy, you must know that the risks of you getting a second breast cancer in your opposite breast for most women is less than 6% in 20 years. So case number 2, we have a 56-year-old African-American female with an abnormal mammogram with a 1 centimeter mass. She has no family history, which is the most common case. She has invasive ductal carcinoma. She's noted to be estrogen positive, progesterone positive, and HER2 negative. So what we discussed with her is that we discussed that she was a great candidate for a lumpectomy plus radiation equals to having a mastectomy. We offered her, she chose breast conservation, so she had a sentinel lymph node biopsy done in surgery. Her lymph nodes were negative, and we also offered her what's called intraoperative radiation therapy, which we'll get into. Now, genomic testing we performed for her, and that is actually the testing of the cancer cells to determine if she is at high risk of recurrence. When we looked at her profile of her cancer cells, her recurrence score was very low, it was 7%. So anything that's less than 10% is considered low. So she actually had surgery. She had radiation done in one day, and she was placed on a pill to protect both breasts over the next 5 to 10 years. So case number 3, we had a 48-year-old woman with a history of a 4 centimeter left breast mass and enlarged lymph nodes in the axilla and complained of lower back pain. The mass had been present for over 1 year. She did have a sister who was diagnosed with breast cancer at the age of 44. The mammogram and ultrasound confirmed the large breast mass. We did do genetic testing, and she actually was positive for the BRCA mutation. So this is a MRI of the spine. The areas in white demonstrate the areas of metastasis. And so the reason why I like to talk about this case is that early detection really counts. The top green line shows the 5-year survival rates for stage 0 is 100%. For stage 1, it's almost 100%. But once you start getting into advanced stage disease, the risks.
I'm so sorry to interrupt. Your slides are not being shared. Thank you.
I'm not sure why. Let's see here. Can you see it now? Wow, went through the whole thing.
Yes, thank you.
All righty. So for early stage breast cancer, as I discussed, the survival rates are extremely high. For stage 3 breast cancer, that's when the survival rates begin to get much lower. And stage 4 breast cancer, the survival rates are significantly lower. So what we know now for stage 4 disease, if you have less than 6 sites for bone metastasis, we oftentimes, treat beforehand. This woman had chemotherapy initially. She had radiation to the spine as well because she was BRCA positive. We did do bilateral mastectomies and an axial lymph node dissection. She had immediate reconstruction, and we did encourage her family members to be tested. So I want to talk a little bit about radiation because it's evolved over recent years. Intraoperative radiation therapy is a technique we've been fortunate to have at our hospital system. It's indicated for women who are over 50 years old. They have a tumor size less than 2.5 centimeters. They're estrogen positive and or progesterone positive. And when we check the lymph nodes at the time of surgery, they're noted to be lymph node negative. So the device is noted to the right of the screen. And so what happens is that that woman would have a lumpectomy done. We would insert the catheter at the time of surgery, and she would have radiation for about 15 to 30 minutes. Radiation today can also be given in a separate form, 1 week, where you have radiation twice a day for 1 week. 3.5 weeks is also used for early stage breast cancer, and 6 weeks today should be used for patients who have very advanced stage disease. So for chemotherapy, what we should know is that actually most African American women present with hormone positive disease. And so we often talk about triple negative breast cancer, but triple negative breast cancer is only noted in African American women approximately 30% of the time. You should also know, as we stated earlier, that HER2 positive disease will also always require chemotherapy. And what's new now is that some stage 4 diseases are now being treated with a pill, as well as some early stage breast cancer diagnosis. So in summary, mammograms should be done for African American women. These are my recommendations, and they also it's recommended by the American College of Radiology at 40 years old. Self-breast exams should be done every month. If you have an abnormal reading, you should act quickly. You should maintain a healthy lifestyle, low-fat diet, exercise, as I stated, and minimal alcohol consumption. Alcohol can actually increase your estrogen levels, and that's the reason why your risk of breast cancer can be increased. Know your family history is key. If you have several family members that had breast or ovarian cancer and now prostate cancer can increase your risk, you should see a high-risk provider, and that's usually a breast surgeon. Breast conservation is a safe option for most women with early stage breast cancer with the same outcome as having a mastectomy. The earlier the stage, the better the survival rates, and lastly, early detection counts. Any questions? There's one question. It says, what causes papillomas? Papillomas, that is actually a growth in the ducts of the breast. In most cases, it is benign. The reason why it has to be removed is because it can be up to a 40% chance of having surrounding cancer cells. The diagnosis has evolved, though. In recent years, only a sclerosing papilloma needs to be removed. So it can slightly increase your risk of getting breast cancer, so we highly recommend that it be removed. Who should have a breast MRI? Women, when you get your mammogram report, if it says heterogeneously dense breast tissue, anything that says dense breast tissue, you should talk to your primary care physician about getting a breast MRI. In some states, it is approved that on your report, they must note that you have dense breast tissue and that you're a candidate to have a breast MRI. Also, women who are noted to be high risk And as I stated earlier, if you're seeing a high-risk provider, then you get a breast MRI once a year. Some women who actually have been diagnosed with breast cancer, and it's noted to be in a couple spots in your breast, in that one breast, we actually advise breast MRI. And so those are usually some of the main indications. Okay, so to the 19-year-old, I've actually, my youngest has been 19 years old. I just operated on 24-year-old this week. The good news is that you're stage 2. The good news is also is that you're estrogen positive. So just for you, you will have close surveillance for quite some time. You probably won't undergo the same protocol as women who are 50 plus. So more than likely you'll be followed by your breast surgeon or medical oncologist for, a significant amount of time. But breast cancer in young women has evolved as well over the past decades. We now can safely offer some women breast conservation, but it does depend on the tumor type. How often should women get a mammogram? If you are African American, I am trying to get some policies changed. I still agree that we should start at 40. We should still go every year. Now, once you get over 75, maybe that should change. But for Black women, since we have such a high death rate, I still recommend every year. Current guidelines state that between 40 and 45, though you go every other year. Exercise itself, exercise just by the studies, there have been, thousands, I would say hundreds of studies shown that women who do exercise decrease their risk, and that's just because they probably have lower body fat. Most women who exercise eat healthy, and when we look at patients women who have not been diagnosed, those women have a lower chance of getting breast cancer. There is some indication that unhealthy food impacts your breast health. And so we know a high-fat diet, high-sugar diet will increase your risk. When we're talking to our patients, we advise them to limit their sweets and try and eat, just meat and vegetables, a high antioxidant diet. The breast cancer incidence for African American women is 1 in 8. Prognosis depends on stage, but what we do know in the African American population, African American women have up to a 40% chance of dying from breast cancer as compared to their Caucasian counterparts. And so particularly here in metropolitan Atlanta, we have, unfortunately, some of the worst death rates in the country, so there is still some work to do. If women breastfeed their children, there is some data that will lower your risk. Sorry, I'm having a hot flash. There are some recent studies that show, unfortunately, African American women are unable to breastfeed as long as some other women because of their need to go back to work. And so, but there are some studies that show that it will lower your risks of getting breast cancer. So this young woman who stated that she had a breast MRI, they found more cysts in my right breast, they believe are benign. As I stated earlier, cysts have less than 1% chance of cancer. We usually don't operate to remove them. Women state, well, how can I get rid of them? Oftentimes, it's just something that, your breast tissue makes. So if they're painful, then you should limit some of your caffeine intake. For the friend who's losing her taste after being treated for breast cancer, she should follow up with her medical oncologist. They usually, they want to evaluate for thrush. And sometimes they'll give her some type of oral solution to see if her taste can come back. And there are some medications that will increase her taste sensation coming back. Should I be concerned about moles around my breast? You should if they begin to get bigger, they bleed, they change, they peel. You should note that. But one thing about, African American women is that as we age, we get more moles on our bodies. So it may be just part of your genetics, but most moles around your breasts are non-cancerous. As far as milk being, let's see, as far as milk and dairy consumption to breast cancer, there's so many foods that are linked to breast cancer, but when it comes to just some clear evidence, I think milk and dairy products, that's still investigational if we should eliminate that in our diet. Dense breast tissue means that when we're looking at your mammograms, it's very hard to see through the tissue. Say, for instance, you're looking through a piece of wax paper, like what you cook with. That's dense breast tissue. Instead of looking through like saran wrap, so that's like fatty tissue. We can really see through that. To the woman that was diagnosed with inflammatory breast cancer, for the woman that was diagnosed with inflammatory breast cancer, I will tell you the stats that I put up, they are most recent, but your diagnosis of inflammatory breast cancer was not considered in that graph. Inflammatory breast cancer is totally different. And so I would talk to your medical oncologist about your prognosis. I will tell you that the medication that you are on actually has been very successful. Breast implants don't cause breast cancer. It doesn't make it harder to detect because they are now pushing the implants back and you get your mammogram that way. And oftentimes it pushes up the breast tissue so that we can see and feel the breast tissue better. That breast lymphoma that you hear about, that's actually 0.001% of all breast cancers. And so most women, and it's over 99.9% who have breast augmentation, they actually are not at increased risk of getting breast cancer due to implants. Preventive measures we talked about, diet, exercise, low alcohol or no alcohol intake is key, as well as knowing your family history and acting on it, getting your mammograms in a timely fashion. We talked about breast cysts and cancer. Breast cysts have less than 1% chance of cancer and they don't increase your risk. I enjoyed it. I'm so sorry you guys missed my slides. I'm not sure how the team can forward them to you, but I'm available for questions. I think they have my email address and I enjoyed it again.